Hello, and welcome to the Complex Care Journal Club podcast. My name is Kristina Malik. I'm a pediatrician at Children's Hospital Colorado and your host for this episode. In this podcast series, we seek to discuss emerging evidence in the care of children with medical complexity and its implications for practice. I am delighted to have Bethlyn Houlihan and Meg Comeau from Boston University joining me today. Bethlyn is the lead author and Meg is the senior author for the article, What Families of Children with Medical Complexity Say They Need: Humanism and Care Delivery Change. This article was published online in Pediatrics in January 2024 in the Collaborative Improvement and Innovation Network for Children with Medical Complexity supplement. Bethlyn and Meg, thank you so much for being here.
It's a delight to be able to be here and to be able to have the opportunity to really be stewards of the experiences of families from the project. Thank you.
Thanks for having us, Christy. We are big fans of the OPENPediatrics podcast, and we are honored and delighted to be here with you today.
So this publication is one from many from this supplement, with findings from a collaborative improvement and innovation network to advance care for CMC across 10 state teams, commonly called the CMC coin. Before we start, I was hoping that, Meg, you could provide us a brief overview of the goals of the coin.
Thanks, Christy. So in 2017, the Health Resources and Services Administration's Maternal and Child Health Bureau, or MCHB, funded its first collaborative quality improvement project focused specifically on the population of children with medical complexity. The Collaborative Improvement and Innovation Network to Advance Care for Children with Medical Complexity, or the CMC coin, included 10 interdisciplinary teams in different states. The teams were composed of pediatric primary and specialty care clinicians, family leaders, public health professionals, tertiary care children's hospitals, payers, and policymakers. The CMC coin was intended as a learning laboratory in response to a number of emerging challenges, including the continuing growth in the CMC population, increasing recognition of the significant stressors faced by their families, especially around providing and coordinating home and community-based medical care, along with the physical, social, psychological, and financial consequences of those stressors, the rising costs of primary and specialty care, alongside a growing awareness of the inadequacies of provider reimbursement. As the project funder, MCHB had three primary goals for the project: to improve child quality of life and family well-being, and to improve the cost-effectiveness of care for CMC. Child quality of life and family well-being were left relatively undefined by our funder. As a result, we initially focused our quantitative measurement efforts around identifying existing indicators of quality of life and well-being. Our family advisors, to whom we had made a firm commitment to in helping guide the project, said, you won't be able to see meaningful change around quality of life and well-being using quantitative methods. One, because you need to hear directly from the families in the project cohort about their lives and how the project team's interventions were impacting them and their children. And two, because quality of life and well-being mean different things to different families. And so there is no quantitative measurement set that is going to cover all of the bases that are important. So we took a look at existing quantitative quality of life and well-being measures, and we found many issues in them, in the context primarily of ableism. Too many of them appeared to be focused on functional ability as a proxy for quality of life and well-being. I think we've seen some compelling recent work on discrimination and bias in healthcare towards both kids and adults with disabilities, so this concern resonated with the leadership team as well as the family leaders. As a result, we added qualitative data using focus groups to our design. You can learn more about the co-design process with family leaders in the pediatric supplement paper, Measuring What Matters to CMC and Their Families.
So Bethlyn, what were the key findings from these family focus groups?
We had 127 families across 27 focus groups, 10 state teams from around the country. It was a real opportunity to do this network level research analysis for qualitative analysis. So that just allowed us to be more nuanced in how we could look at this and think about what the drivers are for families and really honor their experiences and what they said was really needed to effectively think about and approach improving quality of life and well-being. So in what I'm going to present to you, we intentionally focus thematically in the narrative on what was most important and most missing. So where families were saying the biggest gaps lay, you will see more of the kind of things that you might expect and usually see come up around, like, we need better care coordination and what that looks like in the tables. Those tables that are included provide specific and tangible examples. One of the things that we realized was that we needed to be able to consider first and foremost, where are families coming from? So when they talked to us, it was very clear one of the primary things missing from their perspective was human dignity, just across the board. So not just in care, but the sense of human dignity being in their daily experience. They're constantly counteracting bias so that they can feel like they're recognize their child as valued, each child being valued as a whole child. And then the second theme that we had was what families really need and recommend in care. So there's underneath that, the elements that really rose to the top that families were saying were most important, yet most missing to meet their whole child and whole family needs. Creativity and practice for the whole child, relationship and trust, partnership and communication, and then the undervalued power of family to family support. And I, again, want to point out that those are not, it's not that those are anything new per se, but what you're hearing and what you see from families is when you start from what is most missing for them, that drives what is most needed, and areas that are undervalued by others in the system itself that they feel they really need to have attention drawn to. So with that in mind, I want to focus a little bit on the what's missing, the human dignity side, because when we think about where you can do transformational change, it's in thinking about what are the mental models that we don't even know we're bringing into the picture that are kind of implicit, and that we can then, from families' experiences, from what they told us in these focus groups, we can see where the dissonance lies and be able to then look at shifting our own mental models so that everything else drives from there to look at how we change systems. So when we look at what's missing human dignity, just to give you an example, counteracting societal bias by valuing each child. She is just as valuable a person as any of us. That's a quote. So that gives you a sense like there's just pervasive bias that families are dealing with, including ableism. They just need to know that's the foundational place that we're starting from to understand that experience and then build and design care from there.
I'm also doing some qualitative interviews on a different topic, but with families of children with medical complexity, and finding a very similar sentiment, this idea that when families access care, they have constant, daily, hourly reminders that they're within a system and they're not really within a team. The reminders the families get is not of teamwork. And we know there's humans there every day providing care, but that's not what families feel.
It intersects really well with what happened here. I think it's all part of that same sense of the family saying, look, our child is not a burden. Our child is a joy. And it's this system and the lack of system, really, all around that isn't able to provide the support. And it's this much larger daily experience of feeling they're constantly fighting to say, I just want what we know we need so that my child can just be a child and enjoy childhood experiences. And I think it makes a huge difference for everybody when you're able to bring your humanity into an encounter and into a relationship. And that's not always easy to figure out how to do, but I think that is exactly what families are saying that needs to be elevated, emphasized, and valued as one of the most important things that they need in order to feel like it's improving their daily lives for them and their children.
I think one of the things that really resonated for me in the context of humanism and in sitting in on many of the focus groups was families' hope and expectation that their children would be seen as children and not just as patients, or not just as, the diagnosis in exam room 5 or the kid in ICU bed 2. I think that they really were hopeful that the clinician partners who they wanted to work with would approach them and their need for care in that context. I think there's an opportunity for maybe undermining the power dynamics a little bit when you walk into an exam room or you walk into a hospital room with the feeling and the perspective that you are a group of human beings who are engaged in a process that is fundamental in the lives of people. And regardless of whether you are currently a provider or not, someday you're probably going to need care yourself, and you would probably like it to be provided in a way that recognizes your humanity and really takes the lessons that many of us learned on the playground in kindergarten into account in providing that care, and really approaching it from a sense of humility and a sense of connection and a sense of, this is the way that I would want my child cared for, or this is the way I would want to be taken care of in this position.
I love the way that you were thinking about when you walk into the room and just seeing that whole child. I have a great quote that just kind of speaks to that I thought I could pull out. In order to get to responsive whole child care plans and just better outcomes, like maybe ask a question like, is he able to get in his gait trainer for baseball? Or are you having a hard time to understand what we are trying to get their bodies to do? Are you finding he's super tight? Maybe we can adjust medication. That really kind of speaks to me of the thinking about that whole child and really considering what they're doing in their lives, and then come to, okay, so what do we do in their care? So starting from that place, and I will say that the families in those focus groups that had the experience of palliative care services, there were, I think, 3 focus groups in which it came up just on its own. And in those focus groups, it was a very strong response of how meaningful what palliative care was able to do to consider exactly what we're talking about. How do we take what that evidence base is and clearly from palliative care and make sure that we're bringing in those tools and strategies? And that would mean for like interdisciplinary teams really leaning on their palliative care folks to help draw that in to humanize care. It would also mean looking to your social workers who do like trauma-informed care, because I think you marry those two together and you have kind of a fantastic combination to really be with families and children and meet them with a sense of shared humanity.
Yeah, the message that families told us over and over again that they got from the world at large is that you are different. You are outside the norm. Your family looks different, and it can be very isolating. Another thing that we heard consistently from families is that the rest of the world just doesn't get it, doesn't get what our life is like, doesn't get what it's like to parent a child with medical complexity, doesn't get what we go through, doesn't get the joys associated with our experience, and also doesn't get some of the hardships and some of the burdens that we experience as a result of deficits in the system that's supposed to be supporting us. And I think one of the ways that that gets expressed is feeling that we heard consistently from the families is that the healthcare team are the ones who are in it with them. My mom doesn't get it. My siblings don't get it. My close friends, I don't hear from them anymore. They've kind of disappeared, but it's our healthcare team that gets it. And so I would imagine if I were a provider that would feel oftentimes humbling and like a privilege, but also like a huge responsibility. And so again, to Bethlyn's point about the importance of and the lessons that we can learn in complex care provision from palliative care, it's not just around the principles of palliative care, sort of the values that palliative care brings to their practice. It's the skills and techniques. They know how to do this stuff. So when the families were telling us in the focus group, ask us the hard questions, have the difficult conversations, ask us how it's going, ask us how we are. If I were a provider, I'd be terrified to ask those questions because I wouldn't know what to do with the answer. Palliative care can help you with that. And so I just really wanted to emphasize that. I think, too, another thing that I've been thinking about a little bit based on both what we learned from the family focus groups, but also what we learned in the conversations and the connections that we developed with our provider teams is that we're trying to push folks to bring more humanism into their practice with and care of families and kids. I think the next frontier in this is to bring more humanism into our care of one another on our interdisciplinary teams, and how we treat our colleagues and how we treat our peers and how we treat our students and how we treat the folks up the food chain from us, and how we all are trying to do this really hard work together in ways that are compassionate and meaningful, but that aren't so heavy that they become sources of burnout for us, or disillusionment, or disconnection, or compassion fatigue. So if we have listeners who are thinking about, well, what's next after this, I would just like to make that suggestion that, it's humanism to patients and families, but it's also humanism to our colleagues and our peers. And then maybe the next step after that would be humanism towards ourselves.
I would love to have you talk a little bit more about how some of the findings could actually transform clinical practice. If there's some recommendations for interprofessional care teams based on the focus groups and how clinicians can actualize these ideals of care.
It's very clear that families feel like providers have a vital role. The experience, when you do have people that get it, it makes a huge difference when a family has a provider on a team that gets it. They aren't just soft skills that you have or you don't. There are very clear ways that you can both build it into structures of care and that you can also learn those skills because there's an evidence base to them. It's kind of exciting, actually, that that's the case. But when you think about what they're asking, there's things, as Meg pointed out, connecting as full humans, caring about the child's quality of life and family well-being as deeply intertwined and recognizing that. So that means like partnering with humility as equals with that family and honoring their expertise because they're the ones that have to do that care every day and keep their child healthy, safe, well, and safeguard against gaps in the system for families, knowing that their well-being is deeply intertwined with their child's quality of life. That means really taking into account and asking genuinely, how are you doing, mom, dad, caregiver, the primary caregiver of that child? That was something that one of our state teams, Colorado, came up with, #JustAsk, indicating that you're really open and ready to listen so that you can understand and potentially support in ways that you might not realize were needed. Very important too. And broaching difficult conversations. So really finding ways to do that. Families felt like we don't know what we don't know. And we deeply value, even when it's hard, the times and places when people share and have difficult conversations with us compassionately. And that really is a shared conversation. That's part of navigating uncertainty together. And then also working to improve and coordinate key aspects of care for families. So even if it's not in direct purview, like home and community-based services are huge. Thinking about rec therapy, being able to really do that. One big thing is that referral to peers, like family-to-family organization or family-led organization or other families that have gone through it. And if that family isn't ready for it, to keep offering along the way, because that kept coming up as being so undervalued and critical. Those are some of the key things that families say this really needs attention.
I wanted to pick up on the point that Bethlyn just made about the importance of peer connection and mentoring that we heard over and over again in the focus groups consistently from families. And in part, that's because, to Bethlyn's point, they're the folks who get it. They're the folks who have been there. They've walked the walk. They know the right telephone numbers to call. They know the right levers to pull to get the system to work a little bit more efficiently. But they also get the emotional experience, and it resonates with families to know that they're not as isolated as oftentimes the rest of the world makes them feel. Don't wait until somebody asks you, is there another family that I can talk to? Don't just mention it in an initial diagnosis conversation. come back to it on a regular, systematic basis. Would you like to talk to another family who's having an experience like yours? Especially around times of transition. I think that's incredibly important. And not just transition from pediatric healthcare to the adult system of healthcare, but all kinds of different transitions. So there's transitions from early intervention to the public school system. There are transitions around becoming a teenager. There are transitions around moving communities. There are transitions around there's a new step parent involved, or there's a new baby in the family, all kinds of different transitions. It can be really, really helpful, according to the families, to have those kinds of life experiences recognized by their healthcare team, and then resources associated with them referred to. So if you have an algorithm, or if you have a practice guideline, or if you have some kind of thing in your EMR that is cueing you to do these things, to make these referrals, I think it can be really, really important and can help meet that need.
I agree with you. And I think the onus is on clinicians to talk about and refer, even if they don't know the complete process. Just even mentioning the fact that these things exist sometimes is a huge opportunity for improvement.
And also, being connected to family leadership organizations where peer mentoring, peer coaching, peer support is part and parcel of what they do. They also do a lot of navigation. So that's really, really helpful. You not only get a flyer from many of these organizations, with a list of outdated websites, you get somebody to tell you what telephone number to call, what number to push on the phone tree, and then who to ask for to talk to by name. You can really get some insider information that's incredibly helpful in navigating what is a dizzying array of programs and policies that have not been designed for ease of access.
We've talked a lot about the findings from the study, but I also want to highlight that these methods that you used in conducting your project was also really novel. So can you tell me a little bit about the opportunities and challenges you identified while developing and conducting these focus groups?
I think this is a great question. It went along with how we ended up approaching the whole study under Meg's leadership. And that is really what guided the fact that we said, all right, so we know we need to do these focus groups. And the first challenge was, how are we going to develop the guide? Like, what are the right questions to ask to be able to get at child quality of life and family well-being? So that was an opportunity to develop the family leader work group that was led by our collaborative partner at the national level, Family Voices. And there were family leaders from every single state team represented on that work group. And the guide was, what are the probes that will help families to understand what we're trying to help them think about? Because when you say quality of life and well-being, they're very big abstract concepts. So that was the first opportunity. One of the things with our focus groups, we started with an icebreaker that I think really opened this up for families by recognizing and asking what brings them joy in raising a child with medical complexity. And that actually allowed them to be able to really immediately crack open, like, yes, my child, there is joy and they're a full person, and people don't get that. So I think that was a fantastic way to begin and to think about it, to be able to help families to let us know where they were feeling we needed to pay the most attention.
You mentioned the development of our interview guide, and we would be more than happy to share that free of charge with anyone who might be interested. Just reach out to either Bethlyn or I, and we'd be happy to send it electronically. The other thing that I would say is, Bethlyn mentioned how important it was to the families that we started each of these focus groups with what brings you joy in raising a child with medical complexity. And we got that from this family leadership work group, who told us that so often in conversations that they have, there's a deficit focus right off the top, like, what's wrong? What's your problem today? What brings you in to see me to fix? Oh, this isn't a problem that's fixable, so I don't know what to do now. What is your child's learning challenges in developing their IEP? Those kinds of things are very much from the, you don't have quality of life because you have functional disabilities or limitations. I think that's where that idea may come from. So starting from a place of positivity, starting from a place of what brings you joy in this experience. It was both refreshing, I think, for the folks who are part of the focus groups. And it also, I think, set the stage for them understanding that we were seeing their child as a whole person and understanding that there's a give and a take, a yin and a yang between the things that are hard and the things that are not hard and wonderful about raising a child with medical complexity.
I love the way you said that, Meg. We also had family leaders from each of the state teams that were the facilitators. And we helped to support them and provide training if they needed it so they would feel confident in leading those groups, so that that would create the container for a sense of trust and safety for people to be able to share honestly and openly and feel like that would be understood and received well. And I think that really helped to create some of the atmosphere that allowed for them to give the responses that they did that were so authentic and meaningful.
So what are the messages for children, youth, and their families from the focus groups?
I think that one of the key messages at the clinical level, and I guess part of this is nothing that people don't know, but to recognize they're not alone. So when Meg talks about that isolation, I think one of the key things people got out of being in the focus group, and that I hope if someone were reading this, to feel like their experiences, their sense of what they're seeing as missing and the sense of dehumanization that they've been experiencing, that they're recognizing like, oh, I'm not alone. I'm not making this up, which is what we do as humans. We kind of question ourselves at some point and realize like, oh, no, this really is like all around me. There's these failures and gaps that are not allowing for us to be able to just experience and be a part of the joy of it and be able to live there more. So I think that's one thing that is really important. So there's value, that they have a value and a power in understanding what needs to change in order to tip the scales so that systems of care work better and then improve their lives in ways that matter. So that sense of nothing about us without us, and that providers, they want to be a part, like that special relationship that connects people. So to be able to work together to do something that feels better about trying to shift that and make change for both their sakes, to humanize systems for everybody.
And I know you wanted to give a few takeaways that were really practical for clinicians. Can you give us some of those key takeaways?
I guess if there's a message to be able to say for care teams, it's one, I think that you don't need to be everything. That's part of the point, is that referring and recognizing the power of peers and other families and really building that up, as we've been talking about, that if you're going to look at whole child and whole family, to really learn what families need, ask them authentically and genuinely, how are you? So that you're really getting to those needs. Another thing would be that there are some very clear evidence-based ways to be able to get at focusing on building partnerships and sharing power and communication and relationship and trust. And those include things like looking at the tools and strategies and evidence base that is employed within the palliative care service, looking at trauma-informed practices. There are things like, for instance, motivational interviewing. There's a thing called brief action planning. Those are structures of conversation and skills that you can learn. And you can do that in medical education through role play. You find that to be very powerful, or having people with lived experience that are interacting with, so you can understand how to work with people and be in relationship with them through things that are uncertain for both of you on either side. And also things like care maps are very tangible. And if you haven't heard of those, it's a way of mapping from the family and the child at the center, where they get care on all areas of their life, where it supports what they look like and what they need to be able to stay well and have that quality of life and well-being. And working with schools, because that's the other place where kids are all the time. And that came up quite a bit. And it's something to consider for how to coordinate.
I would add, I think that Bethlyn and I are both very cognizant of the fact that what we are sharing on behalf of the families who trusted us with these messages, some things that are really, really, really hard to put into practice, right? So it's not just about asking the difficult questions and being prepared for the answer with a response. It's also about time. that is a resource that is in such incredibly short supply throughout the healthcare delivery system. And so one thing that I would suggest that maybe we take a step back and think about a little bit is not how am I going to take this message from families and try to apply it within a system, square peg round hole, that's not prepared to support it. Instead, how do I change the system? And so I'm old. I went to elementary and middle school in the 70s. So I was taught a lot of the foundational things that I understand by hippies. And so, blow up the system. Let's not just look at quality improvement from the perspective of how can we nibble around the edges and make some of these processes more efficient, but instead, how can we really look at the deficits in the system and do something meaningful that changes the system so that we can then change our practice and families can receive and kids can receive care in a different way.
Meg, I love that there. That's all I can say. So, what do you think are important next steps from your work?
We are working with our friends and colleagues at the Lucille Packard Foundation for Children's Health in terms of expanding the range and depth of the voices who we're learning from and trying to transmit those learnings more widely and more broadly across the country. Do you want to say a few things about that?
Sure. So that series, The Future of Care for CMC, it's a virtual cafe series we're doing mostly every other month. And we are focusing on different aspects of the system and trying to really open it up so that it's broadening and expanding conversation through an interdisciplinary team approach. So anyone that touches the system and is involved is welcome to attend and to engage in these conversations. We're trying to elicit helping people level up and think about how we work together to be able to shift systems. So all together, we hope that this will really help expand. And then we're going to share out what we have so that people can see those themes and maybe use some of that as they're looking and have that in hand as they're working together to try to shift systems.
Indeed. I mean, we've had the privilege of talking to you today, Kristi, and having just a conversation among the three of us, but we would love for your listeners to join us on those cafes and be part of the conversation and really try to learn from them and their experiences. We'd love to have more public health professionals, especially folks in the Title V MCH, CYSHCN world. We'd love to have more family leaders as part of those conversations. We'd love to have payers come on down. We have a lot to offer you in terms of value and increasing cost effectiveness in terms of care of kids with medical complexity. So I hope that folks will be able to join us and we'll all be able to take advantage of the opportunity to learn together from one another.
Thank you so much for your time, Bethlyn and Meg. Thank you to you and your team for advancing the field of complex care. And thanks for listening to the Complex Care Journal Club podcast. We aim to highlight research that has potential to be practice-changing, that values patient and family engagement, that is relevant across disciplines and diagnoses, and uses high-quality or novel research methods. We invite you to join the conversation by suggesting an article that you would like to see discussed in this podcast using the form provided on OPENPediatrics YouTube channel. Thank you for joining us.